Good afternoon, everybody. Thank you for joining us today for our Lunch and Learn webinar at IRISi about strengthening the healthcare response to domestic abuse and sexual violence. My name's Mel and I'm our head of programs, and I'm going to be joined shortly by our colleague Hayley, who is our network and innovation manager. And today we're just going to walk you through a little bit about IRISi, our work and the healthcare response. Just wanted to flag a little bit of self-care before we come into our content today. We know that domestic abuse and sexual violence are issues that will impact all of us widely, both professionally but potentially personally as well. We're not going to go into a huge amount of detail today, but we will talk through some of the health impacts that victims and survivors will experience, and we are going to talk through a couple of case studies. So we just want to be mindful of that from the top. If you do feel impacted or triggered at any point throughout this session, please obviously make sure that you look after yourself, make sure that you have some support around you and reach out if you can. We will share signposting at the end, so we'll share resources for where you can get support yourself, but where perhaps if you needed those details for sharing onwards for support people you know professionally or personally that are impacted, we'll share all of those resources with you at the end as well. And before we get started, I just wanted to give a bit of recognition to the 16 days of activism. That might be why many of you are here, and it's a big reason for us running this session today. The 16 days of activism started on the 25th of November with the International Day for Elimination of Violence Against Women and Girls. And tomorrow, the 10th of December, marks the end of that period of time with Human Rights Day. We know that domestic abuse and sexual violence are huge human rights issues for adults and children. And that is a huge reason behind all of the work that we do here at IRISi, and I'm sure why you all have joined us today. So I wanted to recognize those that are impacted, but also just take a moment to recognize those that will have lost their lives within the last 12 months to this issue. It's a really serious, pertinent issue that we need to be addressing within healthcare, of course, wider than that as well. So thank you for giving your time to join us today and to spend a bit of time discussing this issue and seeing how you can implement things within your workplace, and how perhaps we can work together moving forward to address these issues. Thank you, Hayley. If you can move us on to our next slide. So just a little bit of what you can expect from today's session. We don't have long together. We only have an hour. So we're going to cover a variety of things, but really as kind of an overview and a snapshot. We will talk at the end about the ways that you can connect with us further. So if you have more questions, we haven't covered things in enough detail and you want to know, we would love to connect with you to kind of talk through these topics in even more detail. But today we will aim to talk a bit about the prevalence of domestic abuse and sexual violence, and particularly the health impacts. That's the focus that we have as an organisation. And as part of that, the critical role that general practices, sexual health clinics in particular, but of course the wider healthcare settings, the role that they play. We'll then talk a bit about our IRIS and our advise programs that sit primarily in those two settings, in general practice and in sexual health, and the way that they work, and hopefully you can get a better understanding of those. We'll also talk a bit about the cost benefit and the impacts of those as well, and talk through some real life case studies from both IRIS and advise, and look at some of how that has worked for victims and survivors and clinicians in practice in real life. And we'll kind of wrap up with a bit of what's next. How can we support you in your healthcare setting? And how do IRIS and advise kind of align with the wider strategies that we see taking place across our health sector, but also across our government within our Domestic Abuse Act too. Thanks, Hayley. So on to our next slide to talk a little bit about IRISi then, who we are. So we are a social enterprise dedicated to improving the healthcare response to gender-based violence. And we very much exist to bridge the gap between healthcare professionals and specialist domestic abuse and sexual violence services working with victims and survivors. We also provide expert advice and consultancy around gender-based violence and those working in healthcare settings, and work on a national scale to ensure that there is best practice taking place, and also the scaling of the programs we have in place at current. And I'll come on to talk about those slightly later on. We're the only national-based organisation that's working specifically across healthcare to improve the responses to domestic abuse and sexual violence. And we simply exist to nationally amplify and push for the need for a specific, tailored healthcare response to domestic abuse and sexual violence. And our ambition really is to develop a suite of interventions and training and support that helps clinicians in practice how to recognize and respond to the needs of their patients that might be experiencing domestic abuse or sexual violence. And we also want to ensure that healthcare staff are supported themselves within that. It's really important that we recognize there is a large population of our healthcare professionals who are personally impacted by this issue and will be supporting patients at the same time. In September last year, NHS England launched their first ever sexual safety charter, and that was really in response to some disclosures that were being made across the NHS of staff experiencing sexual harassment in the workplace. Reports about staff experiencing being offered money for sex, being shown pornographic images, and being assaulted and harassed verbally at work, both by patients they were working with, but colleagues and staff as well. And we also know that there is new research that's come out to show that healthcare professionals are experiencing themselves a variety of ranges of abuse in domestic contexts, so psychological, sexual, economic, physical. That research showed that 90% of the abusers were male ex-partners, and that 85% of abusers had directly interfered with victims' work, and that 92% of those victims and survivors reported that their work and career were directly impacted. And of course, that their physical and mental health were impacted alongside that. So we know that healthcare professionals themselves need support with this issue, as well as ensuring there's support for their patients. And obviously, there's complexities with that. IRISi launched as an organization in 2017, so we've been running for a while, but we have actually been operating in the healthcare setting and the health kind of world since 2011. So we have a great deal of time and experience behind us working around domestic abuse and sexual violence in healthcare settings. We're made up of a very small team, but a really effective, excellent team, primarily of women who have worked in the frontline domestic abuse sector themselves or within the research sector around domestic abuse. So we really have a wealth of knowledge of that real life practice of knowing domestic abuse and sexual violence and what victims and survivors report wanting and needing. And looking ahead, our vision really very much is, as you can see on this slide, a world where gender-based violence is universally recognised as a healthcare issue, not just a social issue, not just a police issue or a criminal justice issue, but a healthcare issue, and that healthcare staff are really equipped, trained, and supported to know how to respond to this. We're very much driven by the survivor voice at the heart of everything that we do. It's why we exist, is to improve outcomes for victims and survivors. And we're very much driven by hope, resilience, and a commitment to creating a future where every survivor of domestic abuse and sexual violence has access to care and support in order to thrive and to become safer. I'm now going to hand over to my colleague Hayley, who is going to run through a little bit about the prevalence of the issue, but also that health impact side that really highlights why, again, we exist and why healthcare need to be responding to this issue. Thank you, Hayley.
Thanks, Mel. So domestic abuse is a national crisis that affects 1 in 4 women and 1 in 6 or 7 men in England and Wales. In the year ending March 2024, an estimated 1.6 million women and 712,000 men aged 16 years and over had experienced domestic abuse. And the year ending March 2022, there were 798,000 women and 275,000 men who were victims of sexual assault. Earlier this year, the National Police Chiefs Council declared VOG to be a national emergency, noting that it has reached epidemic levels in England and Wales in terms of its scale, complexity, and impact on victims. According to the Institute for Addressing Strangulation, an estimated 20,000 victims in the UK experience strangulation each year, and between April 2010 and March 2021, every year, on average, 18% of female homicide victims in England and Wales were killed by strangulation or suffocation. Despite these overwhelming statistics, domestic abuse and sexual violence is still not talked about enough, and around 85% of victims seek help from professionals, on average 5 times in the year before they received effective help to stop the abuse. Whilst we recognise domestic abuse is a gendered crime that disproportionately affects and impacts women and girls, men and boys also experience domestic abuse, and it's important to reflect that domestic abuse has no boundaries and anyone can be affected. Regardless of gender, recorded data will never completely capture the extent of domestic abuse or sexual violence, which we know remains highly unreported, and the statistics we're sharing today are only the tip of the iceberg. Women are at increased risk of domestic homicide, and between the year ending March 2021 and March 2023, it was reported that there were 65.4% females of domestic homicide and 74% of the suspects were male victims. Were male. A recent report from the Domestic Homicide Project found that there were 242 domestic abuse related deaths recorded between April 2022 to March 2023, which included 93 suspected victim suicides following domestic abuse, 80 intimate partner homicides, and 31 adult family homicides. They also found that the victim and suspect demographics remained consistent with the previous years, with the majority of victims being female aged 25 to 54 years old, and the majority of perpetrators being male and of the same age bracket. We know domestic abuse and sexual violence is a health issue, and whilst healthcare professionals are in a unique position to identify and respond to patients experiencing domestic abuse and sexual violence, we must not overlook that healthcare professionals can experience this themselves and will face their own unique barriers to disclose and seek support. A recent study on healthcare professionals as domestic abuse survivors, the workplace impact and support seeking, was published recently following a cross-section survey to understand healthcare professionals' experience of domestic abuse. Among the 192 healthcare professional survivors who responded, all abuse subtypes, so psychological, sexual, economic and physical, were common. 90% of abusers were male, so current or ex-partners, and 85% reported abusers directly interfered with their work, and 92% reported their work and career were affected. Unfortunately, domestic abuse and sexual violence are not always viewed as healthcare issues, and whilst we understand that healthcare services in the UK can be stretched, often seeing patients with repeat conditions and complex health histories, it's vital healthcare professionals understand the impact that domestic abuse and sexual violence, which can significantly affect their patients' health. We know health services are trusted environments and will see people from every background and walk of life who has or is currently experiencing domestic abuse and/or sexual violence. Evidence tells us that 80% of women experience domestic abuse, seek help from health services, and these are often their first or only point of contact. Repeated findings from domestic homicide reviews have highlighted that health professionals can offer patient survivors a safe place to disclose and seek support at an earlier opportunity. Domestic abuse and sexual violence are global public health issues, and the health professionals play a vital role in its response. Therefore, it's critical that awareness about domestic abuse is embedded in the practices of all health settings. On the slide, you can see a few examples, and this is not an exhaustive list of the health impacts of domestic abuse and sexual violence. The presentations in yellow are ones more frequently associated with sexual violence. Those in blue are frequently associated with domestic abuse. All conditions presentations listed affect female victims and survivors, and research supports an association between the health presentations that you can see in bold and italics and male patients who are victims and survivors of domestic and/or sexual violence and abuse. So that's chronic pain, sexual function issues, sexual risk-taking. Of course, we can make an educated guess that men and those who identify as part of the trans and non-binary community will have a wider health impact than these alone. However, we unfortunately have limited research in these areas. We also know the complexities of domestic abuse and sexual violence, and therefore any patient who experiences these forms of violence and abuse may present with either or multiple health impacts. Now let's take a look at some of these health impacts on the screen in a little bit more detail. So gynecological problems are the most consistent, long-lasting and largest physical health difference between abused and non-abused women, the 3 times increased risk for abused women. Gynecological problems include sexually transmitted infections, urinary tract infections, painful intercourse, chronic pelvic pain and vaginal bleeding. Avoiding cervical smear tests is common in women who've experienced sexual violence. Intimate partner sexual assault is associated with vaginal dryness, vaginal irritation and pain with intercourse during menopause. Physical and emotional IPV are associated with difficulty sleeping, night sweats and pain with intercourse. Chronic physical conditions, so gastrointestinal disorders, fibromyalgia, chronic pain, chronic tiredness, emphasise how almost all conditions that can be exacerbated by stress are more common in victims and survivors. Living with trauma has a profound impact on victims and survivors' physical health. When we're tired, stressed, overworked, this can take a toll on our physical health. Imagine someone experiencing any number of forms of abuse we can see, constantly walking on eggshells, being anxious, afraid, nervous, being consistently under high stress within the home. Emerging evidence suggests that experiencing domestic abuse may be associated with worsening menopause symptoms and that menopause may lead to change or escalation in domestic abuse. Nearly 4 in 10 women killed by men in the UK are in the 36 to 55 age range. Menopause-related healthcare appointments can be a key opportunity for intervention with women who may not otherwise disclose or identify their experiences of domestic abuse. We know domestic abuse and sexual violence aren't only physical, but we need to recognise physical injuries like unusual bleeding, cuts, burns, bruises, repeat broken bones. What are the explanations for these injuries? Do they make sense? For example, does the injury align with how the person said they felt or became hurt? Could they indicate assault or self-injury? Non-fatal strangulation may be viewed as a physical injury, but we know the impact often goes far beyond this. Significant health impact might include stroke, particularly in younger women. Strangulation could be the second biggest cause of stroke in women under 40, including brain injury, hemorrhage, stroke, bleed on the brain, memory loss, amnesia, and impact on cognitive function and decision making. Worst case health impact is death. 2 to 3 women are killed every week in England and Wales by a current or ex-intimate partner, and sadly we know this figure is much higher when we include women killed by family members and those that have died by suicide. Although we are mainly focusing on the health presentations for our advised programme for general practice and advised programme for sexual health services, we have and are working in other health areas and support healthcare professionals to identify and use clinical inquiry to support their patients, not only with some of the health impacts on screen, but others more specific to their areas of work. For example, on average, 75% of domestic abuse related injuries present in the head and neck region. Therefore, the dental professional may be the first to identify bruising and marks to the patient's neck, cheek and ears, broken or missing teeth, trauma to the mouth or facial bones. Also, research has found that around 30% of domestic abuse begins during pregnancy. The Royal College of Midwives and Gynecologists have said it's a maternal issue, with maternity care professionals such as midwives and health visitors particularly well placed to identify and respond to abuse. Research suggests an association between sexual violence and a range of mental health problems, including post-traumatic stress disorder, depression, psychosis, and substance abuse problems, and also demonstrates that a high proportion of people in contact with mental health services have experienced sexual violence. And we'll now be looking a little bit more on the next slide about the health impacts on mental health. Domestic and sexual violence can have a devastating and long-lasting impact on the mental health of victim survivors. Both research and data from specialist services have shown that over the decades. Additionally, survivors can often face a range of barriers in accessing mental health support, and often find that the support is available is not appropriate, doesn't recognise the link between domestic abuse and trauma, and often sometimes can cause that re-traumatisation. According to a results study, Breaking the Silence, addressing domestic abuse in mental health settings, domestic abuse has been linked to be a range of mental health impacts, including depression, anxiety, psychosis, schizophrenia, bipolar disorder, and serious mental illnesses, post-traumatic stress disorders, and eating disorders. Lifetime experiences of any type of domestic abuse is associated with suicidal ideation, psychological distress, and depression in women. Both men and women experience physical domestic abuse, face increased risk of depressive symptoms, substance use, and the development of chronic mental illness. Perpetrators will often exploit a victim's mental ill health as well as using medication as a form of abuse. For example, over-medicating or under-medicating, hiding prescribed medication, cancelling subscriptions, or collecting and throwing away medication. Important for a case of suicide that had been an overdose, was domestic abuse present? Could this be a homicide? Now let's have a look at some of the mental impacts on the screen. And again, presentations highlighted in yellow are ones more frequently associated with sexual violence. The rest of the ones up on screen, bear with me. So the woes that are highlighted in blue are frequently associated with domestic abuse. However, there is likely to be a crossover between the two. Research supports an association between the health presentations in bold and male patients who are victim survivors of domestic and/or sexual violence and abuse. Unfortunately, there's a limited research to show the impact on men's mental health, and those presentations in italics are also associated with male victim survivors of domestic abuse. So PTSD, anxiety, depression, alcohol, and drug misuse. Male victim survivors may present with many of the same indicators as female victim survivors. Let's look in a little bit more detail of some of the mental health impacts of domestic abuse and sexual violence. So over 50% of high-risk victims report having mental health issues. 7% of victims report that they have considered or attempted suicide as a result of the abuse, and 17% reported self-harming. Domestic abuse has significant psychological consequences for victims, including anxiety, depression, suicidal behaviour, low self-esteem, inability to trust others, flashbacks, sleep disturbances, and emotional detachment. Domestic abuse victims are at risk of post-traumatic stress disorder. As many as 2/3 of victims of abuse, around 64%, develop PTSD in one of the studies. Between 30 to 60% of psychiatric inpatients have experienced severe domestic abuse, and women who've experienced domestic abuse are 6.5 times more likely to attempt suicide. It's also important to consider how intersection identities could be at increased risk of poor mental health in association with domestic abuse. So LGBT plus victim survivors are almost twice as likely to attempt suicide and more than twice as likely to self-harm. Disproportionately high levels of Black and minoritised women have self-harmed, contemplated suicide, and attempted or committed to or died by suicide, with domestic abuse found to be the causal or contributing factor rather than any pre-existing or diagnosed illness. There is a higher incidence of self-harm and suicide among young Asian women experiencing domestic abuse. Survivors experiencing mental ill health as a consequence of the trauma of being subjected to violence and abuse. The impact of this on survivor, including the coping strategies they employ, such as alcohol or drug use, is not generally well understood, including by some healthcare professionals. Patients who experience trauma may struggle to engage or trust health professionals, perhaps could appear angry or uncooperative. It's also important to think about drug and alcohol use, and drug and alcohol can often be used as a coping mechanism for those experiencing trauma. Victims of abuse have a higher rate of drug and alcohol use that may have started before or after the domestic abuse, and at least 20% of high-risk victims report using drug or alcohol. Perpetrators may exploit a victim's existing drug and alcohol use or coerce them into starting to use or increase use. Women who experience intimate partner violence were almost twice as likely to experience depression and problem drinking. So I'll hand you over to Mel now.
Thank you, Hayley. Okay, so what do we do about this then? We've got lots of patients experiencing lots of health impacts and potentially presenting in healthcare settings. I'm just going to touch very lightly on our interventions. And like I said, if you want to connect with us to find out more, we'll tell you how to do that at the end of the session, and we'll make sure we share follow-up information. Our main two programs are our Advise program based in sexual health and our IRIS program based in general practice. Our IRIS program has been running since 2011 and very much came from a research base. It was based on a piece of research that showed the high levels of women attending general practice. So almost half had been threatened or experienced physical violence, and 74% had experienced coercive and controlling behavior in that study, and yet only 15% had that recorded on their medical record or had translated into a consultation. And so that's where the birth of IRIS came from, to be recognizing that patients are attending general practice experiencing this. What do we do about it? How do we address it? IRIS is now a gold standard domestic abuse intervention, and the success of that model has informed the NICE guidance around effective primary care responses to domestic abuse. And our Advise program is our second intervention, as I said, that sits in sexual health clinics, slightly smaller, but growing, and we're very, very excited about it. Both of those programs offer what you see on the slide, a comprehensive and specialist training package to all the practice and clinic teams that cover what we call the 5 Rs. So, how to recognize domestic abuse and sexual violence, how to ask and then do a risk check, how to respond appropriately, where to refer in, and how to record properly on the medical record. They provide a specialist advocate educator who is a domestic abuse consultant, delivers training and supports patients, and in most cases, a clinical lead who is a practicing clinician within that area. They provide a simple, direct, and one-page fast referral form that goes directly into somebody who usually responds within either 24 hours or 3 working days. And in most cases for IRIS, that's female patients age 16 plus, although alternatives have been commissioned to cover male victims too. And in the most part, it's domestic abuse, although again, some cover sexual violence. And our Advise program is open to all patients of all genders, covering domestic abuse, sexual violence in the context of domestic abuse, but also standalone sexual violence as well. And as we mentioned, all of those programs cover healthcare staff, not only how they respond, but them personally as well. If they're dealing with any of those issues, our staff are there to support them too. And you can see some of the figures on the slide there about the referrals we've had so far. Hayley, if you want to pop those up. That's the areas that we've got commissioned at the moment, the level of referrals that we've received for both. As we said, IRIS has been running since 2011, Advise only for a couple of years now, so she's catching up, but not quite there. There have been evaluations on both of these programs, and again, we can send information through to you on that. But those evaluations have shown for IRIS significant improvements in health outcomes for patients, their mental health and their physical health, and have shown that in comparator to other models and studies that have been done, the programs with practices, with an IRIS program implemented are 30 times more likely to recognize patients and refer them into specialist support. And our Advise program has again shown significant increases in referrals, particularly those that are presenting as LGBTQ plus patients, and really significant high levels of referrals for those experiencing sexual violence. Often when those referral pathways aren't quite as clear, sometimes they may be more clear for domestic abuse, but less so for sexual violence. And our Advise program has really improved not only the recognition of patients experiencing sexual violence, but support and clear pathways for them in those cases. Thank you, Hayley, if you can move us on. So, what does our data say then? We collect data nationally across our programs, and that allows us to show trends and impact. What we see for Iris is that there tends to be an older cohort of patients that are being referred through, which is really important because older patients, particularly older women, tend to get kind of missed or overlooked when it comes to domestic abuse and sexual violence, and not as recognized. Our aging population often can be referred to as kind of a disappearing population. So it's really important that there's a place where they're able to report and be recognized and receive specialist support. We know we saw levels of referrals on that previous slide, but we know that even if survivors aren't referred into IRIS, that being asked and identified by a clinician has really additional benefit. We know that they may come back for a referral in the future and they know where to access support. Our analysis of identifications of domestic abuse by clinicians across IRIS shows that the actual reach of the IRIS program far exceeds the number of referrals that we've received. So, what we have is an estimated at least 15,000, almost 16,000 patients identified within the last year. That could go up to kind of 50,000. So that's patients that may not have accepted a referral, but are being identified and now know where to seek support in the future if they wanted to. We also have for our IRIS programs a positive trend of the mean number of referrals over time. So, what that tells us is that not only are referrals increase when there's an IRIS program, but over time, those referrals tend to go up year on year on year on year. So, more and more patients being recognized and being referred through. And for advise, we see 1 in 2 coming through with sexual violence, a younger patient cohort, and more LGBTQ plus, like I mentioned. So we're seeing that these programs together are reaching different patient cohorts, which is really, really important and valuable. Overall, what some of our data tells us is funding, as I'm sure most of you will be sat there thinking, longer term funding is needed and more sustainable funding is needed. Our research shows us that when there are gaps in a program, referrals reduce and are impacted. We see that gender continues to play a significant role in the experiences of those who are presenting. So, although our programs in Advise are open to all genders and many programs in IRIS looking similar, that actually it still is very much women accessing support, and a lot of the perpetrators presenting there are male. We know that for both programs, we're reaching an unmet need. So, what we're seeing is that most that are accessing those programs and most of those service users are reporting that they haven't accessed support before, or that they have tried to access support and have been unable to. We know we have a lot of victim survivors coming through both IRIS and Advise that are disclosing for the very first time in their lives and haven't accessed support via the police, via housing, social care. So there's an unmet need here in healthcare that's really important for us to see. And that we're strengthening those connections between healthcare and specialist services. We have a really wide network of advocate educators and clinical leads and specialist partners, including by and for partners delivering our programs across the country. And the feedback we've had overwhelmingly is that this improves not only knowledge and confidence in addressing domestic abuse, but connecting with a specialist service so that survivors are getting the support that they need. And mental health, it's clear that mental health plays a significant role in victims and survivors accessing support across both of those programs, as Hayley just mentioned. Thank you, Hayley, if you can move us on. And what about costs? So we talked about funding. I'm sure many of you are sat there thinking, what does this cost? How does this work? We can have those conversations with you. But what we do know is that particularly for our IRIS program, it's been proven to be cost effective. What you're looking at in front of you is cost-effective analysis from a real-life IRISi over a 3-year period. And as you can see with some of the data presented here, it's shown to be cost-effective across not only an NHS perspective, but a societal perspective as well. So for the NHS, we're looking at perhaps changes in how patients are accessing their GP or A&E, or how frequently, how many prescriptions they require. And that societal perspective is wider. So not just the healthcare system, but the legal, civil and criminal systems, the cost of housing, social care, etc. One of the most significant ones on here, I think you can see, is that it says Iris here was 4.5 times better value for money than the flu jab from an NHS perspective. What we know from NICE guidance is that they recommend implementing anything that is less than a £200,000 per year on QALY, which is quality adjusted life years. And what you can see there on the left-hand side is that the cost was almost, but not quite, £1,500. So from that NHS perspective and from NICE guidelines, this program should kind of be rolled out nationally for the money that it saves. Again, there's much more that we could say about this. We don't have the time to cover all of it here, but if you want to get in contact with us, we can absolutely share more, and you can find more about these published findings on our website as well. Thank you, Hayley. And so before we come to look at some real life case studies, why do we need a specific healthcare response? If we haven't relayed enough already, we can see that domestic abuse and sexual violence is a violation of human rights and has a massive, massive impact on victim and survivors' health. And so hugely important that healthcare plays a role in addressing this issue, because the patients they will be seeing are going to be directly impacted by this. We also see that there are expectations of healthcare professionals and the healthcare sector to be responding to this. So both the VAW Commissioning Toolkit and the Domestic Abuse Statutory Guidance that sit alongside the Domestic Abuse Act state that in responding to and preventing violence against women and girls, it should be a strategic priority for both ICBs and ICPs. And there is a responsibility for all healthcare professionals to be working within a system that addresses this. We also have the Pathfinder Toolkit, which is a piece of work that was done a couple of years ago. This describes IRIS as the kind of best practice, the gold standard for addressing domestic abuse within general practice. And the Department of Health and Social Care published its Women's Health Strategy that, again, within that says that there should be a commitment to exploring how victim support services for victims of sexual violence and domestic abuse can be enhanced, and that the ICB's joint forward plans should be taking into consideration how they seek to address this and put things in place. For many, that we know that healthcare is often the first and only point of contact that they have. And we know that 80% of women in abusive relationships seek help from their healthcare service, usually their GP, at least once. And so we have to be putting things in place for victims and survivors and for healthcare professionals to know what to do when this occurs. Okay, I'm going to hand over to Hayley, who's going to introduce two fabulous individuals from our network who are going to talk a bit about what this looks like in real life practice, not just in data.
Thanks, Mom. Okay, just wanted to give you a little bit of a gentle reminder again around self-care, as we are going to be hearing from our IRIS advocate educator and our IRIS clinical lead, who'll be sharing the impact of IRIS in their areas and the impact on survivors too. If you are affected, please take care of yourself, and we'll share the links and national support outlines at the end of the session. First, we're going to hear from our IRIS advocate educator, Alison. Alison has been a member of our IRISi team since 2018 and has experience of working within both of our IRIS and advice programmes. Alison currently is the IRIS A in Tameside, and we are lucky that she's joined us today to share the impact of her role. So welcome, Alison.
Hi everybody. Just to reiterate what's previously been told, this first case study that I'm just going to mention, there is like a little bit of animal abuse as well as domestic abuse as well. So just to everybody take care of yourselves when I'm just going through this. So this is a client that I picked up when I used to work for IRISi. I've now since moved over to IRIS in Tameside, but I did help initially to set up IRISi in Tameside. So at the time, this was a 23-year-old white British woman, and she didn't have any children. She was subjected to emotional, sexual, physical, financial abuse, and there was also the presence of controlling and coercive behaviour within the relationship. And she was with this person for 2.5 years. They were together during lockdown, and that's when things worsened. His angry outbursts were worse once he'd been drinking, or if she ever disagreed or challenged him on anything. On one occasion, she found some blood on the wall in a living room, and when she questioned about it, he openly told her that he'd rubbed the cat's nose on the wall so hard and made it bleed as it ripped a little bit of the wallpaper off the wall. So during the relationship, he was very controlling. He'd tell her what she could and couldn't wear, had issues with who she spoke to and who she didn't speak to. On one occasion, he told her that it was just a beautiful summer's day. He didn't want her to go out wearing the shorts that she had on. He felt they were too short for her. They were going out with his friends and, their partners as well. She refused to get changed, and when she did so, he then stripped off and said, "Well, if you're not going to get changed, then I'm going to go out wearing my boxer shorts." So to prevent any further altercation, to prevent any argument, any issues, she then went and got changed and did as he wanted. So during the relationship, he'd want to have a threesome with other women. He introduced her to men and told her that he wanted to watch other men have sex with her. She always felt uncomfortable, but felt like she couldn't say no to him, as she was fearful of his reaction, as he would make life at home very difficult for her, preventing her from going out. One evening in December 22, they went to a swingers club in Bury. She didn't really want to go to it, but she was forced into it by a partner. When they arrived, she didn't feel comfortable and asked her partner several times to leave. Eventually, they left after he caused a scene in the club, and the bouncers had to evict him from the club. Once outside, he physically assaulted her, and it was caught on CCTV, which was later used in court, because they could clearly see him punching her to the point to the face, and he punched her so hard that he lifted her off her feet, and her glasses flew across the road. When they arrived back home that evening, he locked her out of their flat, and basically she was kept knocking on the door, and he eventually let her in. When he let her in, he punched her to the face and he strangled her. She lost control of the bladder and she lost consciousness during the assault. When she later came round, she then tried to escape. He chased her and tried to drag her back by her hair, and she was so fearful of him that even though he had clumps of her hair in his hand, she still kept running, and there was big clumps of her hair left on the floor. She got into a car for safety, but as they'd been drinking, as a way to punish her, he then phoned the police, and he was doing that stood outside the car because they'd been drinking. So he reported to the police that she was intoxicated and that she was going to drive. She didn't drive, she just sat in the car really fearful. So the next morning, round about 9 o'clock in the morning, the police arrived and saw her partner with the black eye. They asked to see her immediately because they'd found a clumps of hair in the corridor of the flat. Upon seeing her, they arrested him and took her to hospital as she was bleeding from her ear and had extensive facial, neck, and chest injuries. At the time when that happened, the police or the hospital didn't make a referral to the domestic abuse service in the area. At that time, if we'd received a referral into services, it would have been a high-risk merit case, and she would have been allocated an IDVA and she would have been offered support. However, the referral that came in, because at a later date, she'd been to the sexual health clinic for a checkup, and whilst there, they actually asked her the question. So she'd gone 6 months without any support. So the police, nor anybody at A&E asked her the questions, and nobody did the referral to the domestic abuse service. As a result, so when she went to the sexual health clinic, the referral was made via advice and she was given support. But at that point, she was at desperate need for support. So since the referral was made at the time, I supported the client in getting her some therapeutic support, some special measures in court. I liaised with the police and witness support on her behalf, advised on Claire's and Sarah's law disclosure for future relationships. She was put on the Freedom Programme. She was advised on housing issues, how to seek a non-molestation order, legal options, and I've also undertaken a target hardening assessment on a property, providing her with a Ring doorbell, a spy hole and CCTV, and an extra light for security. I also offered support in her telling her parents about some of the intimate parts of the relationship, because she was really worried about her parents being in court and hearing the other bits and pieces. So she didn't know how to tell her parents. So I helped and supported her with that as well. As she'd been strangled, I also liaised with a GP and requested that an appointment with ear, nose and throat was made so that a scan could have been undertaken on her neck to check for any lasting damage because of the non-fatal strangulation. He has since been sentenced, and it was before the law changed in relation to non-fatal strangulation, so he wasn't charged with non-fatal strangulation, he was actually charged with ABH, and also assault by beating as well, and he received 34 months in jail. And he actually received a 10-year restraining order, and when he gets released, a curfew order as well. Following on from that, the client, she ended up in a new relationship several months afterwards, and she actually contacted me after I closed the case because she wanted some advice and help in relation to that relationship, because she was having the red flags. She could see the red flags. There was some gut feelings as well that something wasn't right. So she contacted me and she ran past some of the behaviour, and she actually worked out that it was another abusive relationship. But she's since moved on and she's now in a healthy relationship and she's pregnant as well. So, like with the right help and support, she has been able to move on. It'll always be with her, but she was able to move on, and it's quite a nice outcome, even though it's quite horrific what she went through at the time. So that's one case which came through IRISi. This is another case which has come through IRIS, so it's a GP who's referred this case. So again, another domestic abuse case, but this client is a 42-year-old white British woman. She continues to live with her abuser, who's a 21-year-old son, and at the time she had a full-time job, but she was off sick due to stress. So the initial appointment was undertaken, and it took place at the client's mother's address at her request, and her daughter, who was 22 years old, was also present. Because all three women had actually been physically, emotionally, and financially abused by her adult son. So throughout the appointment, she spoke quite openly, although she was in tears a lot of the time, so was her daughter. But they were really worried about some of the behaviours. The 21-year-old as a child had lots of neurodiversity issues, and he'd been for lots of tests. He was offered lots of support. He'd had anger issues as well. He was bullied at school. And what had happened is at every point, he'd actually declined support. So as an adult now, he's an adult with lots of issues. Mum, when she was in a relationship with Dad, Mum has since disclosed to me. She said at the time that Dad had actually abused her in any which way possible. She's since started to disclose a little bit more with me, and Dad was basically beating her up. At one point, you couldn't recognise her face. This is like 23 years ago, because he beat her up that much with a crowbar. So she's never had any help and support in what happened to her when she was younger. And she's then gone on to have two children. One of them's done really well. Her daughter's done really well, who's at university, who's thriving. And then she's got a 21-year-old son who is emotionally abusing her. There's lots of concerns as well about physical abuse, and the threats that he's making. He's smoking an awful lot of cannabis within the family home. There's issues with the neighbours who are reporting him to the neighbourhood team as well. So potentially they could be at risk of losing the property. Mum ended the relationship with Dad when this now 21-year-old was only 4 months old. So it could have had an impact when she was carrying him, which we know can happen, but he doesn't have any memories of any of the abuse. But he's kind of like mirroring Dad's behaviour. So there was lots and lots of issues. Mum had never phoned the police. Nobody had ever phoned the police on him. They tried lots of things. When he shouted, Mum would recoil. She was absolutely terrified of what he would do and things like that. And she'd hide herself in a room. There's locks on her bedroom door, locks on daughter's room, because he'd basically come in, he'd take things from the room and he'd sell them. So when I first started working with Mum, she was basically, you give her a little bit of advice and she'd back off. However, we've managed to get her some EMDR therapy, which has been absolutely amazing for her. She now speaks to me on a regular basis, and there's been an update since I wrote this report. So the week before last, she actually texted her sister just the word police, because her son again was threatening her, and he'd picked up a weight from the top of the stairs and he'd thrown it down 2 flights of stairs at her. damaging the ceiling, the smoke detector and the front door. The police have turned up upon her sister phoning the police and they've arrested him. Mum has actually gone ahead with pressing charges. He's got bail conditions not to contact her and not to come back to the family home. But Mum's been really worried that this is a 21-year-old son. Where's he going to be going? He's sort of like, he's saying that he's sleeping on the streets. She's now found out he's actually staying with paternal uncle, so she feels a lot better. And she wasn't sleeping, she wasn't eating. It was having a huge impact on her physical, mental, emotional well-being. She's now able to sleep. I've also supported her to go to a GP practice as well, because 2 weeks ago I was speaking to her after she sent me a message basically saying that she was feeling very suicidal, and she'd been online and looked at ways to actually end her life because she didn't know how else this was going to stop. So we supported her to go to the GP. We managed to get a medication review. The doctor's going to keep a close eye on her as well. And this is all of a case of because of the training that we've done and the support that we've given her. So she's now saying that she's feeling an awful lot better. She knows she's still got a long way to go, and we're still going to keep supporting her and offering that help. But there's been a huge difference for her. She's now able to sort of like everything else. This 21-year-old knew that he could do whatever he wanted to, and Mum was going to back down. However, things recently have significantly started to change, and she's now sticking with what she's saying. She's saying, no, unless you change your behaviour, I will not have you back in the family home. So he's now saying that he's going to get some medication. He's now saying that he's going to get some therapy. He's now saying that he's going to get some help and support. But we know with abusers that they can say these things, but whether he will stick to it is another thing. So that's just a very, very quick overview of two of the cases that we've had, one from Advise and another one from Iris as well.
Thank you, Alison, for sharing them two very positive and very powerful case studies. We're now going to hear from Pradeep, who's a GP and an IRIS clinical lead in Havering. And I've been personally lucky to have been working closely with Pradeep and the rest of the amazing IRIS team in Havering, who've only been running for less than a year and are already seeing some incredible results from IRIS in their borough. So welcome, Pradeep.
Thank you, Hayley. Thank you everyone for inviting me to talk on this. So I'm Pradeep, I'm a GP in Havering and also the clinical lead for the IRIS program as well. So what my role involves is going into practices and delivering the training. So it's split into two separate clinical training sessions. The first part is around sort of identifying, risk stratifying, and how to sort of ask the questions around domestic abuse as well, because one of the things that clinicians struggle with is actually how to open that conversation if you're suspecting someone is experiencing domestic abuse, because this isn't something that's really taught in any of our medical training, whether it's for doctors or for nurses or really any of the allied healthcare professionals either. So that's something that's very, very useful, and a lot of the clinicians' feedback is that that part of the training is extremely useful for them because they do tend to struggle with that. What we also do, and as has already been mentioned, is that we don't just go in and deliver the training, but it's about ongoing support for practices. So not just the advocate educator, but myself do share our details with all the practices that we've trained. And I think we've trained about more than half, or gone and started training more than half the practices in Havering now. And how that supports the practices that clinicians feel that they have a point of contact. So even if it's a question around, I've got someone here, how do I broach that topic with them? Or someone's disclosed experiences of domestic abuse, what do I do next? Do I raise a safeguarding referral? Should I do a MARAC referral for this? So we're available to them. And I think that sort of support just helps empower them and allows them to sort of take on the training, ask those questions to patients that they might suspect of experiencing domestic abuse, and refer as well. And I think that's one of the things that's helped with the success for us locally as well. Another thing we have done is we've also trained a lot of the healthcare professionals who are part of the ARR roles. So within the different PCNs in our borough, we've been providing them that training. And what we find is actually clinicians like mental health practitioners or social prescribers tend to spend a lot more time with patients. So usually their consultations can last up to an hour, and they tend to ask a lot more questions around relationships, home life, other things like that. And we found that a big sort of increase in the number of referrals are actually coming from those professionals as well. So it's just another opportunity to sort of ask these questions and to understand if patients are experiencing domestic abuse. For the clinicians that we have delivered the training to, they found it extremely useful. They've contacted us afterwards and said that it was extremely valuable. A lot of them was probably hesitant going into it, thinking, this is a 2-hour long session. What am I actually going to get from this? But at the end, we found that there was a lot of engagement with a lot of the practices. And we try and do it in small groups, just because there's always individual cases that clinicians bring along. There's always sort of unique challenges in each practice that we need to tackle. And everywhere we go, we learn something new from those practices. And we like to think that they learn something as well. And it's, a lot of the clinicians that are sending us the referrals now are grateful for the program, because it's given them the sort of confidence to ask about domestic abuse and refer patients on. And what they're finding is actually a lot of these patients used to repeatedly present with sort of physical symptoms, mental health symptoms, but when the domestic abuse was disclosed or asked about and they were referred to appropriate services, these patients got the treatment that they needed. They were getting the support and the help that they required. So a lot of these repeat attendances and frequent visits reduced significantly in number. But yeah, it's a great program, and a lot of the practices that we have trained up have been very, very grateful and found it very useful as well. Thank you.
Thank you, Pradeep.
Thank you, Hayley. A huge thank to Pradeep and Alison for all of the work that you're doing on the ground to support healthcare staff and victims and survivors as well. We'll move on, Hayley, to our final slides. We will share a PDF of all of these afterwards for you. What happens next and how can we help you? So hang on with us for a couple of moments, and we'll share a QR code in a minute where you can access and provide your details, so we can send you follow-up information if you're happy for that to happen, sign you up to our newsletters. We can support in a variety of ways. Is that bringing IRIS or Advise to your area? Having a conversation about those programs and what that looks like? Are you outside of general practice or sexual health and you're thinking actually some domestic abuse, sexual violence awareness raising would be really helpful for our staff? If we haven't got a full model, we can explore those things with you. Consultancy work. So, are you developing policies for domestic abuse and sexual violence? Are you having those initial conversations and want to get a more of an idea of what needs to be in place? And are you a advocate yourself? Are you working in healthcare sessions? Are you a domestic abuse champion, or you're thinking about bringing in domestic abuse champions? Perhaps we can support with training those individuals and working and rallying alongside the work that you're doing. Thank you so much, everybody, for joining us today. It's been a pleasure. And thank you for all the work that I'm sure you're doing already around this issue.